Now, first slide again. What are the common driving injuries I told you? Barotrauma of descent, ascent, decompression sickness, emotion pulmonary edema, oxygen toxicity, nitrogen narcosis, right? So, descent we have seen, and pulmonary edema we are not going to see. It's going to be a simple pulmonary edema only. Conservative management is more than enough. So, now we are going to see the ascent. Barotrauma of ascent means you need to write about the Alternobaric Vertigo, Pulmonary Barotrauma, Arterial Gas Embolism and Decompression Sickness. Decompression sickness is very important, which is once asked recently. So, what is Alternobaric Vertigo? Okay, during ascent, when the patient coming from down the water to the surface, that is from high pressure to a low pressure, what will happen? The air will expand, right? So, air will expand as the pressure decreases. This is all you need to know about ascending pathophysiology. So, air will flow through the ostia of the sinuses and expanding air in the middle ear will open up the eustachian tube. Okay. So, what they are trying to tell? They are trying to tell that, see, this is the middle ear. Okay. So, he has achieved equalization at the 100 feet depth, right, by various maneuvers. So, now he has this much amount of volume. When this guy comes to the surface, the same middle ear box, the cavity is going to be the same, but the volume of air is going to expand twice. There will be a lot of air here, right? There's so much of air into the middle ear cavity. So, what the body does, it will open the eustachian tube, and through the eustachian tube, it will let out additional air. So, the patient becomes normal. Okay, the same is true for sinuses. For example, at 100 feet depth, the frontal sinus will be filled with some air. Okay, so imagine that he has already maintained equilibrium. So, now this guy comes up to the surface, right? So, whatever air is present here is going to increase in volume. So, there's going to be a lot of air in the sinus. So, what the body does, it will open the sinus ostia and it let all these extra additional air outside to the nasal cavity. Okay, this is a normal mechanism. Now, the question is, what if this eustachian tube is blocked? What if the sinus ostia is blocked? So, this additional air in that particular segment, let it be the middle ear, let it be the sinuses, it's going to cause a lot of trouble. Okay, this is called as a barotrauma of ascent. Okay, you got the concepts? So, during ascent, air will expand as the pressure decreases. Air will flow through the ostia of sinuses and the expanding air in the middle ear will open the eustachian tube. Especially this is what happens when you take off in an airplane, right? So, you are sitting in the airplane at the sea level. So, now suddenly it's going to the higher area where the pressure is very less. So, in your middle ear, whatever volume of air is present is going to be doubled or even tripled. So, that part that will cause severe pain in your ears. So, when you open your eustachian tube, the extra air will flow through the eustachian tube to outside. Okay, so you will get equilibrated. That's what happening when you take off in an airplane, right? If air be trapped temporarily in one middle ear cavity, okay, the pressure differential may cause unequal vestibular stimulus in the brain, resulting in vertigo. This is called as Alternobaric vertigo. This is usually transient and generally requires no specific treatment at all. Second is pulmonary barotrauma. This is what I told you. When the patient is there at the depth of 100 feet below the sea level, say this is the volume of air. When he is suddenly coming to the ground level or the zero sea level, this volume of air is going to expand. Okay, if he is coming with a closed glottis, then this expansion of air, the expand of air in the lungs is going to cause pulmonary barotrauma. So, air expands within the lungs with ascent. If the diver ascends with a closed glottis rapidly in panic fashion out of air ascent, the expanding air causes parenchymal lung injury. This is called as pulmonary barotrauma, pulmonary overinflation or burst lung syndrome. Okay, this is all again a very important question. Burst lung syndrome can lead to pneumomediastinum pneumothorax. Okay, pneumomediastinum is going to be very simple only, not so life-threatening. Conservative management is required. Pneumothorax on the other scale also. If it's too much disturbing, then the standard treatment, how you handle a pneumothorax, whether it's going to be needle thoracostomy or a tube thoracostomy, you need to do it adequately. But of course, understand if you are subjecting this patient under HBO, then you need to relieve all these pressures. You need to put an ICD, take the pneumothorax off, then only you can subject to any type of pressure effects. Okay, if the air enters the pulmonary venous circulation, okay, there's more amount of air. If it's not able to come out through the ostia or the eustachian tube, if this enters into the venous circulation, it can get embolized into the arterial system as well. Okay, the most sensitive end organ to such embolization is the brain. This is called as cerebral arterial gas embolization. It is called as arterial gas embolization. From now onwards, anywhere here in our seminar, when you see AGE, it means arterial gas embolization. Okay, and moreover, any neurological symptom or sign referable to the circulation of CNS The patient who is coming from down, that is 100 feet down or 33 feet down, from there he is coming to the sea level, then is there anything that is concerning with the CNS circulation in setting of barotrauma, then it is cerebral arterial gas embolism unless otherwise proved. Okay. Now coming to the decompression sickness. For even the cerebral arterial gas embolism also is going to be conservative management only. You need to stabilize the patient till whatever the embolism is present is going to slowly come out of the circulation. Okay, because once it goes to the arterial embolization, it can go to the venous side and it can slowly wean off or get absorbed. If still is not getting absorbed, then you need to recompress it. You need to go for recompression maneuvers where your HPO can help you. So now coming to the decompression sickness. Can you see bubbles coming up? Why are the bubbles coming up here? We'll see that. So decompression sickness, pathophysiology. So the reason behind this decompression sickness is obstructive and inflammatory effects of the inert gas bubbles in the tissues and vascular system. This is your exam question. This is what you need to exactly write in your exam. Okay. So decompression sickness is a sickness of ascent basically, where the patient goes inside somewhere 100-200 feet below the sea level and now he comes up. So once he comes up, the volume of air is going to expand and now it can cause bubbles in the tissues, in the ligaments, in the fluid. So those things is going to cause some amount of change inside the body. That is called as decompression sickness. What are the changes? The changes are obstructive or inflammatory in nature. Okay. So in whom it can occur? Diverse breathing compressed air, the caisson workers, high altitude pilots or astronauts. Okay. Bubbles may form when a body with additional inert gas in solution experiences a decrease in ambient pressure that causes liberation of gases. Okay, when the pressure decreases, whether from deep sea is coming to the sea level or from sea level is taking a flight and going to the surface or the sky. So the pressure decreases, so the air increases, the volume of air increases, causing bubbles. Okay, so uptake of inert gas occurs at different rates in different tissues. So how actually this is causing this kind of inflammatory pathology or obstructive pathology? On the first place, there should be pre-existing gas micronuclei in the circulation to form a nidus, right? So around which all the other bubbles also get colloid, forming a bigger bubble. So it can cause obstruction and other inflammatory issues. Okay, bubbles form directly in the tissues or circulation as well. So where will it form? Will it form in the arterial system or it form in the venous system? Okay, this is primarily what I am trying to tell is where the pressure is comparatively low from the deep sea. That's very high pressure is coming up, right? So when the pressure is very much minimal, it is there, the gas is going to form, the bubble is going to form. So in your body where the pressure is less, is it in the arterial system or venous system? Venous system, right? So that is why the venous bubbles are more common than the arterial bubbles, right? Now, these bubbles directly obstruct the blood flow, leading to direct ischemia. I am saying about the venous ischemia. So air blood or the air endothelial surface initiate inflammatory and thrombotic process when they come across such kind of bubbles. This activate the endothelium, neutrophil adhesion, activation and opening up the permeability of the endothelium, resulting in the third spacing, like what you see in sepsis, right? Decompression stress induces production of microparticles as well. This is your third mechanism. So this is actually a lipid bilayer enclosed membranous vesicles excluded from the vascular endothelial cells, and this can cause severe cyst-like picture itself. Coming to the classification of decompression sickness. So now you know what is decompression sickness, right? It is a barotrauma of ascent. So from the deep pressure, when the patient coming to a relatively decreased or less pressure, the volume expands. When the volume expands, there are a lot of bubbles created. More commonly, it can happen anywhere, muscles, tissues, venous system, even arterial system as well. More common in the venous system because the pressure in the venous system is very less, right? So this is how the decompression sickness comes up, and it can cause obstruction and inflammatory pathology as well. So how are you going to classify? This classification is basically on clinical methods only. It is type 1, type 2, type 3. Type 1 is only pain only. It's called pain only DCS, where the pain is the deep pain in joints, extremities, unrelieved but not worsened with movement. It won't get worsened, okay? And skin changes like mottling, pruritus and color changes can happen. This is called as cutis marmorata, okay? So sometimes if you are attending any MCQs, they can ask you what is cutis marmorata. This is type 1 DCS, type 1 decompression sickness. What is type 2? It is more serious, okay? There you will have neurological issues, pulmonological issues, cardiovascular issues and vestibular issues in type 2, okay? Pulmonary is called chokes, where cough, hemoptysis, dyspnea, substernal chest pain can occur. Cardiovascular collapse and death can occur. Neurological sensation of truncal constriction, paralysis can occur. and vestibular staggers, that is vertigo, hearing loss, tinnitus, all the vestibular symptoms can occur. What is type 3? Type 3 is similar to all these things, but it's not because of the venous blocks, it's because of the arterial blocks. So once the artery is involved, I told you it's the brain which is very, very sensitive, right? So once the arterial bubbles occur, the patient can have brain CNS related symptoms also. So symptoms of DCS2 noted above plus a variety of stroke syndrome symptoms and signs is type 3 DCS. So a little bit of it. Clinical features of decompression sickness. Type 1 is also called pain only decompression sickness, involves the joints, extremities and skin, the cutis marburata. The lymphatic obstruction can occur in type 1 causing lymphedema, which usually takes days to resolve despite recompression therapy. Okay, type 2 involves the CNS, spinal cord in compressed air divers. Diver means going down from the sea level. It's mostly the spinal cord which is involved. And brain in high altitude decompressions. From the sea level, a patient is taking a flight or some astronaut, okay, and he's going up. Okay, so when you go down, it's the spinal cord. When you come up in the sky, it is actually the brain, okay, which is actually getting more affected. It's not a 100% true statement. It is relatively spinal cord in compressed air divers and relatively brain in the high altitude decompression issues. And of course, the patient can have vestibular symptoms and cardiopulmonary symptoms, which we explained previously. Now, coming to the factors, generally, the symptoms of decompression, when it will occur? The symptom of decompression doesn't occur at the depth, right? It actually occurs when the patient is coming to the surface, when the pressure changes from heavy pressure or severe pressure is coming to a lighter pressure, the volume increases, right? So the issue happens at the surface. Usually it happens within minutes to several hours, but understand in very, very, very rare cases, these symptoms can occur days after diving as well. Okay. So symptoms get worse upon resurfacing. It is actually at the resurfacing, understand, at the surface, not at the depth, as the inert gas load has increased and ambient pressure has decreased. This is one reason where you can see our own people in swimming pool, when they come up, they start coughing, right? And flying with the resultant decrease in ambient pressure may precipitate or worsen symptoms. For example, this particular diver has gone to 100 feet sea level, okay, and he has come up to the zero level, that's the mean sea level. And now if he is taking a flight immediately the same day and night, he is trying to fly, then he is risking his life. Okay, flying with the resultant decrease in ambient pressure can precipitate or worsen symptoms. For this reason, divers are generally advised to refrain from flying for at least 12 to 24 hours after the last dive. Now coming to the symptoms, the pain. Due to the distension from bubbles in ligaments or fascia, intramedullary bubbles at the end of long bones, activation of stretched receptors by the bubbles in the tendons, all these things can cause pain. Okay. So how sure are we that this pain is only because of this kind of bubbles? It could be a tissue injury, it could be a fracture, it could be anything, right? So how sure are you? The mechanism of simple distension of tissues. This is supported by the fact that there will be a rapid improvement of symptoms if you recompress. If you subject this patient for recompression, there will be rapid improvement in the symptoms of pain. Okay. The common pain locations are knees, shoulders. For some reason which is not known, it is actually one single joint usually affected. It is not like every joint in the body. Okay. It's mostly the patient comes up with only one single joint getting affected for a reason not known. Pulmonary symptoms generally seen after more prolonged exposures. Okay. So this also you need to keep in mind. Pulmonary symptoms is seen after more prolonged exposures. But cerebral symptoms occurs with minimal exposure itself. This is one reason in divers who are just exposed to only minimal time period, they go down, they pick up something and they come up, it's hardly 20 minutes or hardly 15 minutes, so they don't get a pulmonary symptom. But some people who are going to very deep area, they are spending 3-4 hours, they are more prone for developing a pulmonary symptoms. So people who are go just for 15-20 minutes, who come up fast, they are more prone to develop CNS symptoms. Okay, this is also very, very important fact. The pulmonary symptom generally is seen after more prolonged exposures. P for P, pulmonary prolonged, remember that. Okay, because large number of pulmonary artery bubbles occur. So symptoms are cough, hemoptysis, dyspnea, substernal chest pain, sometimes cardiovascular collapse and death can occur. Neurologic symptoms begin with the sensation of, the first symptom is truncal constriction or grill-like pain, severe pain. Then a soft woolly feeling begins in the feet, developing onto a ascending paralysis. They mimic something like a transverse myelitis. Okay, this is actually rapid in onset, tends to affect the lower cervical and thoracic regions. Okay, these are neurological symptoms. So now coming to when I say this kind of ascending paralysis, when I say this kind of transverse myelitis, understand the spinal cord is getting affected, but it is not like what you read in ATLS. It's not like anterior spinal artery syndrome or posterior spinal artery syndrome, or in that, for that matter, you will not be able to localize the level of spinal cord affected itself, because it is not at one particular level. It is a diffuse spinal cord issue or a scattered spinal cord issue. You will not be able to point out one single area or one single level or one single spinal syndrome for this matter. Okay. So, and moreover, autonomic involvement with resulting incontinence and sexual dysfunction can occur. So, what exactly happens in spinal cord? Okay. Initial bubbling in the low pressure venous plexus system that first impedes, obstructs the venous outflow from the cord. As we told you, there will be bubbles in the venous system which causes obstruction. Okay. Decreasing venous blood flow prevents dissolved nitrogen in the spinal cord tissues from egressing or regressing, and in situ bubbles within the spinal cord develop called as autocanthus bubbles. So, bubbles within the spinal cord. So, this can cause obstruction to the venous flow and it can initiate even inflammatory cascade. Coming to the vestibular symptom, vestibular decompression sickness usually occurs after deep, long dives. Signs of vertigo, hearing loss, tinnitus and disequilibrium. Okay. So, I just want to tell you about one point about the patent foramen ovale. Okay. So, I told you that at the depth there is high pressures. From the high pressures, when the patient comes up from high pressure to a low pressure, the volume is going to increase, right? So, if there is no enough vent for the extra volume to go out or equilibrate, it's going to form troubles. So, they are going to cause bubbles, right? So, it's more common in the venous system. When there is patent foramen ovale, whatever bubbles in the venous system form, it can get communicated to the arterial system as well. Okay, affecting the artery is very, very dangerous, right? A DVT, deep venous thrombosis, is very easy to accept than a myocardial infarction, right? So, arterial thrombosis is very, very, very severe compared to a venous thrombosis. That's what I'm trying to tell you. So, a patent for ovale is actually a little dangerous. So, closure of a large defect will reduce arterialization of venous gas emboli. Now, coming to this arterial gas embolism. Arterial gas embolism occurs when air enters the left side of the vascular system, the left side heart, left heart. Air inadvertently introduced into the venous circulation can cross the right side of the circulation from intracardiac or pulmonary arteriovenous shunts. Okay. So, inadvertently the air enters into the left side system, left ventricle, and goes to the arterial system. The most dramatic effect is, of course, the brain. We all know this, right? So, symptoms will be loss of consciousness, seizures, blindness, disorientation, hemiplegia. Okay, this usually improve. The symptom usually improve spontaneously when the gas enters from arterial system to the venous cerebral circulation and gets absorbed. Okay, till that time you need to only conservatively manage the patient, but identification of this is very, very important. In that case, the patent foramen ovale should be closed. Rarely, dive related AGE. Okay, so dive related arterial gas embolization from pulmonary barotrauma causes immediate apnea and cardiac arrest. Okay, so this is morely because the air is in the entirety of the large arteries. The complete arteries are shut down and the venous system is shut down. Then they can have something like an obstructive shock as well. So, and the patient can have cardiac arrest. The effects of AGE secondary to pulmonary barotrauma usually occurs on ascent or immediately upon surfacing. Understand this. This is usually not occurring at the depth. Now, coming to the diagnosis. How are you going to diagnose? Understand, you are going to diagnose only by CHE, clinical history taking and evaluation. Okay, only this. There is absolutely no criteria. There is absolutely no criteria to detect this kind of decompression sickness or arterial gas embolization, right? But in your exam, if they specifically ask about this question, you can write about the San Diego Diving and Hyperbaric Organization criteria. Okay, this has a high degree of specificity, 90%, and sensitivity is only 53%. Okay, it is for this reason I say there is no gold standard criteria to detect these two syndromes. Okay, there are certain studies which say that using the cutoff point of more than 2, it has a sensitivity of around 94% and specificity of around 85% to detect the arterial gas embolization. Okay, so what is this SDDH, San Diego Diving Hyperbaric Organization criteria? Is this? It's basically a time criteria. Any of the following signs and symptoms within 5 minutes, you give 3 points. Or these symptoms, give 2 points, and this give 1 point. Okay, totally cumulatively, if it's more than 2, then there's a prediction that the patient is suffering from either the arterial gas embolization or decompression sickness. Okay. So what are the points you need to see? Disorientation, sudden loss of consciousness, aphasia, hemiplegia. This should occur within 5 minutes. Any of the following signs. Then give 3 points. Any of the following. So second is hemiparesis, monoparesis, seizures, new onset, cortical blindness. Give 2 points. Any of the following signs. With resurfacing or discovered during the ED evaluation, a rapid uncontrolled ascent or any ascent with panic and also the symptoms is very short. Give 1 point. Hemoptysis, presence of barotrauma on chest radiograph, pneumomediastinum, pneumopericardium, pneumothorax, again give 1 point. Creatinine phosphokinase greater than 2 times normal, give again 1 point in the absence of skeletal muscle trauma. Now coming to the lab test. Understand, lab tests are useless. Let me be very frank and open with you. It is not with the lab test that you are going to rule in or rule out this condition. Okay. For evaluation and supportive measures only, you are going to do the laboratory testing, not for confirmation of diagnosis. Let's be very clear about it. So what test you will send? You can send the basic complete blood count, creatinine phosphokinase and liver enzymes. Okay, of course the real enzymes as well. So cardiac enzymes, if chest pain present or shortness of breath present, only you can send, otherwise there is no much use of it, because a moderate elevation of cardiac enzymes can be present in decompression sickness as well, because this is arterial embolization, right? It need not be a clear-cut MI or myocardial injury. Hematocrit may increase because there is third spacing. You remember we discussed about the third spacing because of the inflammatory cascade that will be leaking and third spacing. Thereby the hematocrit can get increased. The CPK and other enzymes also become elevated second to the systemic distribution of bubbles. Okay, the degree of elevation of CPK corresponds to the severity of embolism, directly proportional. Okay, remember, I'm repeating it again. Arterial gas embolism and decompression sickness are clinical diagnosis and cannot be ruled in or ruled out based on the laboratory testing. Now, imaging not of much help, of course. If you feel the patient can have a pneumomediastinum or pneumothorax, then you do a chest X-ray. There could be subcutaneous pneumothorax which is grading to the neck as well. Those things can be found out in chest radiograph. And in head CT, do it when there is neurological symptoms which is not clinically, you're not able to catch up with the proper diagnosis. Go ahead with the CTs of the head. You can even rule out other diagnoses. Understand that a patient coming down after a diving episode need not have only diving related disorders, right? That patient can have any disorder. The patient can have a real-time myocardial infarction. The patient can have an SAH, STH, anything which can happen in the land can happen inside the sea as well. So you need to think of other causes for neurological symptoms like hemorrhage, stroke, SAH, anything, right? So although that maybe you will see some gas bubbles, but if you don't see a gas bubble, it doesn't mean that you can rule out arterial gas embolization. Okay, so CT scan is not that much use in detecting arterial gas embolization, but definitely do it to rule out other causes of altered sensorium or neurological symptoms. MRI brain, there is no proper timing to tell at what time can correlate better with the clinical evaluation. But if the patient is having severe weakness, you can go ahead with an MRI to find which area is involved. So now coming to the treatment of decompression sickness and arterial gas embolization, basically the barotrauma of ASCENT. So how are you going to treat? First is 100% oxygen. Okay, because you are going to handle some kind of ischemia, right? Arterial block because of a bubble, venous block because of a bubble. So basically you are dealing with some kind of ischemia. So start with your 100% oxygen. Of course, your A, B, C technique follows. Airway, breathing, circulation. Apart from that, I'm saying you 100% oxygen. Increasing the tissue perfusion with IV fluids, the patient is going to be dehydrated because of third spacing as well, and rapid recompression whenever possible, when there is no contraindication exists. Understand, you need to place the patient on supine position, not Trendelenburg position. Even for arterial gas embolization, don't keep the patient on Trendelenburg position, keep on supine position. Patient may improve spontaneously on surface oxygen and can even have a complete resolution of symptoms. Okay, but we recommend if there is a HPO therapy available, you go ahead with HPO therapy because HPO decreases recurrences and relapses of symptoms. Okay, so recompression therapy, HPO. You need to know how this HPO works, the mechanism. Sometimes they will start asking you like a decompression sickness, and part B of the question or part C of the question can be on the HPO, hyperbaric oxygen. So you need to know what is the indications and in what all conditions you can do this, what is the mechanism of HPO. You should have some idea about HPO as well, okay. So mechanism is the administered pressure, that's a severe pressure you're going to put, right. So pressure, when the pressure increases, what happens to the volume? It decreases, right. So administered pressure decreases the size of the bubbles, number one. So if there is an artery which is blocked by a bubble, when you increase the pressure, the size of the bubble decreases so that the blood flow resumes. High partial pressure of oxygen, HPO is a high partial pressure of oxygen area. So high partial pressure of O2 in solution increases the inert gas washout from the bubbles and tissues. It's only the oxygen which is inside. All the inert gases like nitrogen are washed out. So mass action dictates a gas will travel down pressure gradients, right? So when you give lot of oxygen to this particular patient, so oxygen will take up from what you give, that is from the solution, from the blood to the tissues. So tissues will eventually utilize oxygen, right? Now you are giving only oxygen or a big amount of oxygen and very scarce nitrogen. So the nitrogen from the body, from the patient, from the tissue will come back from the tissue to the solution or the blood because of the concentration gradient, okay? So mass action dictates a gas will travel down pressure gradients. Therefore, nitrogen will move from bubbles with a high partial pressure of nitrogen into plasma, where it will travel to the lungs and be exhaled. O2 from plasma with the high partial pressure of O2 will enter bubbles and diffuse into cells, reduce bubble size as well. The HPO decreases tissue edema as well, increases O2 delivery. When there is edema decreasing, the circulation resumes O2 delivery to ischemic tissues. It decreases the ischemia reperfusion injury by reducing neutrophil activation adhesion to the endothelium. The other thing which was tried is IV lidocaine, okay. So suddenly, from where does this IV lidocaine come is that usually in CABG, cardiac procedures where some amount of air embolus can happen, this air embolus can go to the brain as well. There are adequate papers which say that if there is a suspicion of arterial gas embolization, especially to the brain, IV lidocaine is helpful therapeutic adjuvant for cerebral arterial gas embolization. It decreases the neuropsychiatric deficits when given during anesthesia for cardiac bypass, okay. Bypass operations commonly cause entry of air into the arterial system. So now this slide I just wanted to put, may not be for your exam, but as an emergency physician where you're going to work throughout the world, this is one hotline and a website, the Diverse Alert Network Emergency Hotline, okay. Like how we know the toxicology phone number, whenever there's a toxic case comes, we call the toxicology number, right? We have the AIMS toxicology protocol number. We call them, we can ask for help, right? The same way, wherever you are in the entire world, if you call them, they will guide you how to handle a deep sea sickness or the diving disorders. Not only that, they will provide you the information location of the nearest HBO therapy, the nearest recompression facility around the world, okay. So know this, you can copy it down as well. So may be helpful at one point of time. So this is for your exam purpose. What are the beneficial effects of hyperbaric oxygen therapy? Number one, it provides hyperoxygenation. So once you give more oxygen, ischemia comes down. Second, limits toxin production, inhibits the microbial endotoxin, right? Bacteriostatic and bactericidal, reduces tissue edema, it induces vasoconstriction basically. So stimulates angiogenesis, production of more amount of oxygen dependent collagen matrices, okay. Promotes osteogenesis in hypoxic bone by providing osteoblast stimulation, promotes wound healing, diminishes the inflammatory responses, augments the fibroblast replication, blunts ischemia reperfusion injury, increases the red cell flexibility, enhances the leukocyte bacterial activity, preserves intracellular ATP, terminates lipid peroxidation, okay. By terminating the lipid peroxidation, you can actually obviate the tissue destruction. So this is how, these are all the things by which you can say that HPO is beneficial, okay. This is for just for your exam purpose. Have at least 5 points in your hand so that you can write your exam. And regarding indication as well, this is also for your exam purpose, at least know 5 or 6 indications for HPO. So acute ischemic events, arterial gas embolization, which we are seeing now, decompressive sickness, central retinal artery occlusion, sensory neural hearing loss, select problem wounds, that's certain wounds only, exceptional blood loss anemia, and traumatic injuries like crush injury, compartment syndrome, other acute ischemias, acute thermal burns, compromised grafts and flaps, and sudden gas toxicity like carbon monoxide poisoning. We have a separate seminar on it. Cyanide poisoning, infections like crocodial myonecrosis, the gas gangrene, necrotizing soft tissue infections, intracranial abscesses, refractory osteomyelitis, radiation injuries, osteoradionecrosis, soft tissue radionecrosis. So at least know 5 or 6 indications for hyperbaric therapy. Now coming to the last 2 points, the nitrogen narcosis and oxygen toxicity. This is more of a completion thing, but why this nitrogen is given a specific slide is, nitrogen is an anesthetic by its own, right? Nitrogen is anesthetic by its own. So more amount of nitrogen if it's getting dissolved in the blood, then it is an anesthetic by itself. So imagine that you are in the deep sea and you get a nitrogen narcosis and you faint, right? So, inert gas narcosis occurs when air is breathed at the depth of 100 FSW. What is FSW? Feet sea water or greater. Okay. Symptoms: loss of fine motor skills, loss of higher order mental processes, can diverge to engage in dangerous or foolish activities during deep dives. So, deep dive like 1000 feet down the line into the seawater, suddenly this diver starts behaving dangerously, foolishly. Okay, so this is called as nitrogen narcosis. In certain movies you would have seen, right? They go deep inside the sea and suddenly they start doing foolish things. So, that could be because of nitrogen narcosis. So, at depth greater than 300 FSW, unconsciousness may occur from the anesthetic effect of nitrogen because nitrogen is forced to get dissolved. Just a word about oxygen toxicity. Oxygen toxicity usually affects the lungs or brain. Okay, this is more important, depending on the partial pressure of oxygen delivered and the duration of exposure. So, what you need to understand is pulmonary means lower partial pressure for longer duration. Okay, lower partial pressure for longer duration. Understand, lung is almost a friend of oxygen, right? It takes in and does things with the oxygen, right? So, it needs lot of exposure actually to create toxicity in the pulmonary vessels. But compared to that, cerebral oxygen toxicity, high partial pressures with short exposure itself can happen. So, this is the reason we routinely see cerebral oxygen toxicity rather than pulmonary oxygen toxicity. This is again the reason why we say even in ARDS or other cases also, do not keep very high oxygen levels. You should write a target oxygen level in every patient. Okay. So, pulmonary oxygen toxicity is unusual in diving due to long exposure required to develop symptoms. Okay. Usual diving period is going to be half an hour or 1 hour, right? So, these patients less likely to have pulmonary oxygen. Okay. So, this is only for completion's sake about the oxygen toxicity. The partial oxygen is more than 1.4 atmosphere. Usually, it is then the patient can develop a cerebral oxygen toxicity. Some divers breathe nitrox. Okay, you might have a 2 marks in nitrox as well. It's actually oxygen enriched air with fractions of oxygen 32 to 36%. Okay, it's called nitrox. Okay, nitrogen plus oxygen. It's a enriched air. So, when they are breathing such kind of air, then these issues can happen. More amount of oxygen toxicity. Therefore, cerebral oxygen toxicity can occur at lesser depths and actually in the limiting factor in diving depths with nitrox. Okay, so people who are using nitrox for oxygen, they don't use it for a longer duration. There are not only nitrox, in certain rebreather system, the closed circuit system, diver breathe with a continuous circuit of gas that has a very high fraction of oxygen, that is more than 95%. Then imagine that with the carbon dioxide almost scrubbed off and washed off. So, he is breathing a very, very high oxygen concentration, right? With these systems, cerebral oxygen toxicity can occur at the depth as little as 25 feet. Even certain swimming pools will have this kind of 25 feet depth, right? So, they can have complete oxygen toxicity at this level if they are breathing so very high oxygens. Okay. So, what are the clinical features? Twitching, nausea, paresthesis, dizziness and seizures. Treatment is going to be only conservative. Okay. Limit the oxygen supply to that patient. Give only as much as required. So, treatment is going to be very conservative. Okay. So, these are the diving disorders. So, when you see about questions on diving disorders, you need to know about what will have when the patient descends into and what happens when the patient ascends, and what is decompression sickness, what is arterial cerebral gas embolization, what is nitrogen toxicity, and what is oxygen toxicity, nitrogen narcosis, of course, the immersion pulmonary edema as well, right? So, imagine the 3 laws. Whenever this question is asked, whatever subject is asked in this matter, you need to write these 3 laws. Understand that. You need to write, you are expected to write the 3 laws. You are expected to write all the 5 complications. Okay, the ascent, the descent, the immersion pulmonary edema, decompression sickness, the angio air embolus, the nitrogen narcosis, oxygen toxicity. You need to write all these things, right? And then come to a specific point. Whatever they ask, you need to write it down. With the symptoms, you need to write whether it's because of the ascent or descent, whether it's because of the increase in pressure or decrease in pressure, and how we are going to manage it. Okay, start with your ABC and end it out. And if at all you're writing about HBO, they can ask about the indications and what are the conditions, what are the mechanism, what are the benefits of HBO. And of course, when you're trying to give a patient HBO therapy, make sure there is no contraindication, right? Like tympanostomy has to be done, we all discussed, right? So, this is what is the diving disorders. This is one gray area where you can score maximum marks in your exam. Okay, all the best. Thank you.